All right, Ham, in 30 seconds, take it away.
Welcome, everybody, to the NurseHack4Health Pitch-A-Thon, where we're catalyzing a healthy environment where both nurses and patients can thrive. Next slide. So we have a fairly robust agenda today. So to the audience, you will get a break, we promise, although it'll only be for 5 minutes, but then you'll get a longer break when the judges are deliberating. And to our teams, really, really good luck. I can't wait for everyone to hear your solutions. And to the judges, I think you're going to have your work cut out for you today. Next slide. So how did we get here? So in 2021, McKinsey & Company had a workforce survey which showed that some of the decisions for leaving the bedside are a presence of a safe environment. So people really wanted to have a safe environment to work in, feeling valued by their organization and heard. Also, compensation was very important. And then the ability to care for their family. And then access to development opportunities, including potential for advancement in education benefits. Next slide, please. And then the American Association of Critical Care Nurses also showed within a healthy work environment, there are lower intent to leave the job. There's much less moral distress. And because of that, there's better staffing. And of course, if there's better staffing, we can really provide good patient care. Next slide. So when you hear from the teams, each team will be solving one of the focus areas. The first is attracting, onboarding, and developing nurses to thrive. The next focus area is addressing bullying and violence within healthcare. Third focus area is creating innovative care delivery models. And of course, we always leave an empty bucket, meaning that teams can solve for a problem that we didn't anticipate or know about. Next slide. So of course, none of this would have been possible without thanking all our volunteers. The coaches, you were amazing. Your expertise guided the teams. And of course, Marion and I tested all the team's innovation. And to our mentors, Nico, Kasha, and everyone else on this call, it really is a team effort and a team sport. And then some of our special workshop guests that provided lots of information and education to our teams. Next slide. So let's meet the organizers. First, we'll meet Sanciel, and I am the president of Sanciel, and my day job is director for the Center of Innovation at Mass General Hospital in Boston. And Sanciel, our mission is to really upskill and elevate nurse innovators because we truly believe they're the transformative agents to contribute to healthcare reform. Next slide. So what's next? We have a patient safety technology challenge that you can go on, and this is nursesknow.org. And if you do have an idea, please put that in, and we will be giving $5,000 to that team that wins. Of course, we want you to join our tribe, and you can do that at sanciel.org. And of course, you can read about all those shift disruptors in the Rebel Nurse Handbook. And I will turn it over to my colleague, Kathleen McGraw.
Sure. Hi, everyone. I'm Kathleen McGraw. I'm the Chief Nursing Information Officer at Microsoft. Very excited to be here. Really looking forward to your presentations. I will be your timekeeper, just so you can hear my voice. I'll come off, I'll take my video off at that time. I just want to say at Microsoft, we are committed to the healthcare industry because we realize that optimal health is necessary to achieve our mission, which is to empower every person and every organization on the planet to achieve more. And in particular, our clinical providers, our nurses, their well-being is top of mind. Our point of view really is that regarding the workforce crisis and burnout, the root cause is the workplace, not the worker, and we address burnout by transforming the workplace. So I'll go over and hand it on to Linda.
Awesome. Thank you so much. And hi, everybody. Linda Benton with Johnson & Johnson. I'm so thrilled to be here with everybody today. And again, wish all the teams the best of luck. For those of you who may not be as familiar with J&J and our work to support nurses, I can assure you it's been a part of the company for a very long time, as you can see on the slide, over 125 years. Because we truly do believe that nurses are critical in terms of the importance of transforming healthcare. That's not going to happen without the work and the brains and the insights of nurses on a day-to-day basis. And of course, when you think about the focus of this particular the hackathon that led to this pitch-a-thon, we are also very much behind the fact that a healthy work environment is absolutely critical to really support and advocate for the profession as a whole. So that's one of the reasons we're so excited about being here today with everyone. If you go to the next slide. In terms of what we're focused on today, from a J&J perspective, it's all about working with our partners to attract and strengthen an innovative, thriving, and diverse nursing workforce empowered to advance health equity and transform healthcare. So notice I did not say recruit and retain. That was very, very intentional. And I would encourage everybody on this call to take that language out of your repertoire. And let's aim much higher, really aiming for a thriving and diverse nursing workforce that can really power up and utilize all the insights that you have to change healthcare. 3 key pillars of our strategy. And if you're interested in learning any more about any of these programs, you can always reach out to me on LinkedIn, or this information is on our nursing website from J&J as well. But 1, we're always going to be a passionate advocate for the overall impact of the nursing profession. 2, we are working with partners in events like this one to catalyze that workplace culture and environment where nurses can thrive. And 3, we're also big champions of the fact that we believe the nursing workforce, like all healthcare providers, should really mirror the communities that they care for. So we're very much focused on strengthening diversity in nursing at all levels, and also helping to support readiness to practice, because we know that there's a huge change that happens when someone comes out of nursing school in the first 1 to 2 years, where up to 50% of new nurses will exit those first roles. So again, congratulations to all the folks today. Thanks very much. I'm going to turn things over to Kasia.
Thank you, Linda. I'm Kasia Laskowski. I'm the Executive Director of the Thrive Global Foundation, which is the philanthropic arm of Thrive Global, the behavior change technology company that was founded by Arianna Huffington to end the stress and burnout epidemic around the world. I'm here representing All in Wellbeing First for Healthcare, which is an initiative that was founded by Thrive Global Foundation in partnership with Harvard Teach Chan School of Public Health and Creative Artists Agency, alongside the Dr. Lorna Breen Heroes Foundation, really with 2 main aims. One is to advance solutions to protect health worker well-being, and the other is to dismantle barriers that exist to preventing healthcare workers from accessing mental health and well-being resources. So this pitch-a-thon is squarely in line with that first and, in many ways, the second goal, to really advance these solutions and dismantle barriers to help you all thrive in your environments. And we're very grateful to be here, to be supporting this pitch-a-thon with the opportunity to win $150,000 from our grant funding, and that will be provided in partnership with our partners at Johnson & Johnson Foundation, who have been key supporters in our work. So wishing you all congratulations to making it as finalists, and we're very much looking forward to this. So good luck, and I'll pass it over back to Linda.
Great. Thanks so much, Kasia. Okay, so let's go to meet the judges. And of course, an event like this would not work without having an amazing panel of judges to help us work through the different pitches. So I'm going to ask each one of our judges to introduce themselves in order that you see on the slide, and we'll start with Dr. Goldberg.
Hello, I'm Michael Goldberg, and I'm the scholar in residence at Schwartz Center for Compassionate Healthcare. I'm a pediatric orthopedist, and I've been interested in workforce well-being since before it was in vogue, going back to the 1980s.
Awesome. Thanks, Dr. Goldberg. Kathy?
Good afternoon. This is Kathy Howell. I'm the Chief Nursing Executive for UC Health, which is the University of Colorado Health System. And I'm kind of in the middle of this with all of you. I lead over 9,500 nurses, and I feel your pain, but I also see the innovation that you're all doing. So I'm excited to be here today.
Awesome. Thanks, Kathy. Robin?
Good afternoon, everyone. I'm Robin Begley, CEO of the American Organization for Nursing Leadership, also serve as Senior Vice President and CNO for the American Hospital Association. I'm really thrilled to be here. This is the second time I've judged something like this, and the innovation and creativity of our frontline just inspires me. We're really happy to be here today with all of you.
Thanks, Robin. Katie, we'll go to the next slide.
Yes, hi, I'm Katie Boston Leary. I'm the Director of Nursing Programs at the American Nurses Association. I oversee nursing practice and work environment issues and Healthy Nurse, Healthy Nation, and really excited to be here, and good luck, everyone.
Thanks, Katie. Riza?
Hi, this is Risa Mauricio. Thank you so much for having me as one of the judges here this afternoon. I'm an advanced practice nurse in critical care and a professor at the University of Texas Health. Like you, I'm very passionate about well-being of our nurses. In fact, currently having a research about that topic funded by All In and the Entertainment Industry Foundation. So thank you so much for having me and looking forward to your pitch.
Great. Thank you, Riza. And Richard?
Well, welcome everybody. My name is Richard Westfall. I'm a professor at the University of Virginia in wonderful Central Virginia. I'm also the co-director of the Wisdom and Wellbeing Program for UVA Health and one of the team members leading a HRSA grant in this area. I also led the Department of the Navy's team in the development of the stress first aid model. And I have been in this field of doing the work for care for the caregivers and being the nurse's nurse since 1992. So I'm really glad I'm no longer the only person in the room. So I'm looking forward to this. Thank you.
Awesome. Thanks to all of you. Again, we're thrilled to have you here. And I just love your backgrounds and all that you're bringing to this event today. So thank you. I'm going to turn things over to Marianne Leary, who's going to get us all ready to start the pitch.
Hello, everyone. I am super excited to hear all of your pitches. And thank you again to the judges and all the volunteers and organizers. This has been an amazing event that's been taking place for months now, and really looking forward to hearing the solutions and how you're addressing the problems that we've identified. So just a reminder for our teams who are pitching, you will have 7 minutes to pitch. Kathy will be timekeeping. She will cut you off at 7 minutes. And then we'll have 3 to 4 minutes approximately for questions from our judges. I will be introducing each of the teams as they begin, and then in the chat, Nico will be letting you know who's coming up next. So for the presenters, please monitor the chat so that you know when you're coming up next. All right, so with that, I'd like the team from Christiana Care, Heart, to kick us off with their presentation.
Marianne, right before they start, I will give a 1 minute notification.
Right before they end, is that what you mean, Kathy?
Yeah. Before the first team starts, just so for all the team knows that I'm hearing an echo.
And for our judges, while we wait for Kathleen to fix that, it is application 342. Team is Hart, and the nurse lead was Bridget.
Thanks, Nico.
I think it's fixed now.
All right, so Team Hart, whenever you're ready, you can start.
Hello, we are Team Peach Blossom. Meet Taylor, a newly hired nurse to a medical surgical unit at the hospital. They received a phone call from Human Resources informing them to report for their first day. Taylor also received an orientation schedule via email. She needs to change this. They open it up on their phone, hoping it includes some directions. After finding their way to the elevator and up to the unit, they encounter the charge nurse, who was not expecting them, and learns that their preceptor is out sick. Taylor is placed with the only other available preceptor, who was surprised to have an orientee. Luckily, Taylor manages to make it through their first day. However, continuing throughout their orientation, Taylor receives communication via email, text, multiple other applications, and even paper. Taylor's preceptors all struggle to keep track of checklists, schedules, checklists, and milestones. To any nurse, does that sound familiar? At our organization alone, the past year, we have hired 551 Taylors. Many organizations have recently experienced high turnover, and research shows that about 17% of newly qualified nurses leave their job within the first 12 months. The average cost of turnover for a bedside nurse is estimated to be about $50,000, resulting in the average hospital losing between $6.6 to $10.5 million each year. With 5 million nurses in the U.S., this equates to a loss of $42 billion. Yes, billion with a B. Each percent decrease in RN turnover can save the average hospital an additional $380,000 a year. The cost of turnover can have a profound impact on diminishing hospital margins and needs to be managed. The opportunity is to improve the first-year experience and retain these nurses in their roles. While this is costing organizations millions of dollars each year, it is also leaving patients without the care of appropriately skilled and trained nurses. So why are nurses leaving within their first year? Examples include orientee preceptor mismatching, a lack of leadership engagement, competing priorities, and variability in training standards and support. In order to attract, retain, and develop our nurses, we need to ensure that new hires, preceptors, and nurse leaders are prepared. So let's think back to Taylor. There are many great resources available to nursing staff. However, they are fragmented and often difficult to access using multiple platforms that do not interface. We need a tool that pulls everything together into one seamless hub that is efficient and easy to use and leverages emerging technologies to put critical information at the nurse's fingertips. Our initial target users for this solution include about 500 newly hired nurses annually into our organization and about 1,000 preceptors and nurse leaders, with a vision to market this to nurses globally in the future. So introducing HEART, helping engage, attract, retain, and train. It's a hub for newly hired nurses, preceptors, nurse leaders, and educators to communicate, track orientation progress, and provide resources like policies, well-being, and more. You may see an app here, but we challenge you to think futuristically. We will tap into revolutionary generative AI to create more efficient systems for nurses. For example, matching preceptors and orientees based on existing characteristics such as learning preferences or needs of opportunity. This will be a foundational product created by nurses for nurses. There will also be features to protect data, privacy, and security. This could be the new hire interface. Highlights include quick access to their schedule, preceptor assignments, and a chat functionality for in-the-moment educational needs, or for questions such as, where's my class today? Or how do I care for a patient with a chest tube? Orientees' weekly goals and progress with orientation elements will also be displayed, and wellness check-ins are front and center because we know that newly hired nurses are very vulnerable to burnout. And since this is a bi-directional proposed solution, this could be the preceptor interface. HEART provides easy organization for preceptors to track orientee progress. Both preceptors and orientees can earn badges and rewards as they progress through orientation and beyond.
Looking at our competitors, we were unable to find a comparable solution. The market currently offers learning management systems from vendors such as HealthStream or Saba, or project management platforms like Microsoft Office and Google. And while these applications do provide excellent services, we did not find a product which blends their functionalities to create a one-stop shop platform in a way that feels effortless and at the fingertips for the consumer. This application also allows for both preceptor and new hire development opportunities. We are creating the solution for a nonprofit academic center health system, which serves Delaware, Maryland, Pennsylvania, and New Jersey. Within Delaware, we are the largest private employer with over 13,000 employees and one of the top 10 employers in the Philadelphia region. This platform would be piloted within units of the highest vacancy and turnover rates prior to expanding across our healthcare system. When successful, we envision marketing this platform to any healthcare system or any employer who utilizes a multi-preceptor model of training with a need for real-time dynamic communication between multiple trainers, leaders, and orientees. Here is a look at our proposed budget. For year one, partnering with our Health and Technology Innovation Center, we will utilize our own internal resources to build our application and apply the grant money for research, design, and development of the generative AI functionality within our app. The $150,000 in years 2 and 3 will also then be focused afterwards on using our existing resources and infrastructure to test and implement our solution. If we could decrease our own nurse turnover by half, we could save at least $1.5 million. That's a return of investment of 10 times just in our organization alone and in 1 year. And we want to take this globally.
1 minute.
We already have executive sponsorship from our chief nurse executive and the generative AI steer at our organization. In addition to sponsorship from our leadership, our organization's Health and Technology Innovation Center is committed to partnering with us in consultation with the generative AI experts to develop the solution for our own use and to market to other organizations to aid in retaining their talent and avoiding costly turnover. Our team listed here represents 93 years of collective experience, with more than 50 of those in nursing education and development. We are experts in unit-based education, system-wide education, project management, leadership development, and much more. We've all been new nurses, preceptors, and endure the same challenges and barriers we've described, which makes us well suited to create and lead the solution. So in closing, we know that developing learners should always be done in collaboration with the learner, faculty, organizational leadership, and heart. Reflecting on Taylor's distressing new beginning, let's now imagine that when Taylor first began their orientation, they utilized the HEART app.
Well done. Everyone's completed.
That one's
All right, thank you all. Sorry, I couldn't get off mute. So we will now take questions from the judges. I see that we have some hands up here. Go ahead, Catherine.
Kathy,
Sorry.
Kathy? Yes, that's fine. That's fine. Thank you. My question for the team, and I just want to make sure I heard correctly, is your goal or your outcome how you will evaluate the effectiveness, a decrease in turnover by 50%? Could you be clear about the outcomes you expect to see?
Yes, our goal would be to decrease our turnover rate within the first year. We actually, as an organization, have a decent rate currently, and for our nurse residency programs, it's actually less than overall in the hospital. So we would like to have our overall turnover rate be similar to that of those that are in our nurse residency program. So not just for new nurses, but for all nurses that enter our system within the first year, to decrease that by about 50%. Yes.
Robin.
Thank you. A great presentation. Could you talk a little bit more about the preceptor interface?
Sure. So the preceptor interface will enable them to utilize their, like, the functions of the application that they would need when they have an orientee. They could see how many checklists they have to complete, where their orientee is at with their goals, the types of patients they are taking care of. They can also give feedback utilizing the application. So it's different from the new hire interface, because we want to tailor it to the unique needs of our preceptors that are really just as important as the unique needs of our, new nurses as well.
And our goal is really that multiple preceptors working with the same orientee will be able to see common content, as well as communicate with each other about where the strengths and opportunities are for progress. Because that's been a primary challenge within even, I'm sure, everyone's organizations, is really we need them to be talking to each other as opposed to the orientee then telling us what their needs are directly.
Thank you. That was my follow-up question about if it would be accessible by more than one preceptor. Yes. Thank you.
Mm-hmm. Mm-hmm.
Richard, you have a question?
Yeah, real quickly, I may have missed it. What are you using for measuring well-being?
So I'm going to speak a lot about our brand new nurse residents. We do have a whole system-wide team of work-life well-being specialists who work with our organization and are very present up on the floors. So we use multi-modes. One of the tools we use is a stress vulnerability index tool, but we do ask that those nurses are keeping that information private. We provide them with almost an algorithm of, based off of their stress scores, then which resources they should be utilizing within our organization. So what we're envisioning is probably having a very similar or the same tool as at the very bottom of our app page, as something they can do a self-check at the end of their trainings, either that day or that month, at whatever cadence we recommend for them.
Yep, and we will, the features on the application will tie in to a lot of the well-being opportunities and offerings we do already have as an organization, but make it, very accessible, since the nurses will be utilizing this application for other things.
Okay, thank you. Quick follow-up. Are you planning on measuring the well-being of the mentors?
Yes. The well-being information can also be accessed via the preceptor interface. Because we know that preceptor burnout is a thing as well. Sorry.
I believe we're at time. So Katie, we'll get to you can have first question next time. So thank you, Team Peach Blossom. And next up, we have City of Hope, the link. So Team Peach Blossom, if you can stop sharing, and then the link if you want to share your slides.
And for our judges, application 380, the link, Sarah.
Right. All right. Thank you, everyone. Good afternoon. My name is Leslie Hahn, and I will be co-presenting today with Amy Altamar on the link, which is Leadership Innovation in Nursing Center. We want to introduce you to Kim. Kim is a nurse manager, and after 5 years in her role, she's feeling overwhelmed with competing priorities on a daily basis. From the morning when she's dealing with staffing to being concerned about metrics on finance and quality outcomes through the end of the day when she is trying to ensure nothing has been dropped. She is feeling burned out. Kim wants to do her best so that she doesn't let her staff or her organization down and is struggling to complete projects and develop future leaders. She feels inadequate and has reached out to her director, Dawn, for support on how to tackle the daily operational stressors. Her director is also facing competing priorities and doesn't have the time or tools to provide support and is worried she will lose Kim.
Healthcare organizations face a life cycle of leadership. They have future nurse leaders who eventually become new nurse leaders, who over time become existing leaders. And then those existing leaders start to fulfill the pipeline of the future nurse leaders as they learn from the staff who wants to be leaders. All of these groups are faced with increasing demands and a lack of support. The literature tells us that 72% of current nurse managers are planning to leave their roles within 5 years. That will cost $500,000 per hospital per year, which is a $3 billion problem. And then over that 5 years, it equates to a $17 billion problem.
Our solution is the link, which will equip, engage, and empower nurse leaders. The link is a platform that has 4 fundamental modules supporting the life cycle of a nurse leader. In career development, you receive a framework for frontline nurse identification to develop into the leadership role. HARP is a robust leadership professional development curriculum. Succession planning is a methodology built for all levels. And Project Support Center offers templates, tools, and expertise to support nurse leaders. Data analytics will be available as a customizable service for all modules. The link has a variety of access options, from free to monthly fee subscription to customized contracts. For example, if you had selected the project support module, you would get DIY starter kits that include PDFs with life cycle of a project and creating a project charter available free of charge with registration in the link. For a monthly fee, the self-service subscription includes fillable templates for presentations, such as starting a project management tools such as Gantt charts and stakeholder analysis, and asynchronous expertise to support your nurse leader. At a negotiated fee, you can get customizable contracted service options such as coaching, analytics, and even on-site implementation support. Revenue generated from the link would be reinvested to build on the content of the link or enhance the capabilities of the platform. The link modules will equip, engage, and empower Kim and all nurse leaders to excel in their roles. The link is the only platform that provides free leadership development and project management expertise. The link offers full spectrum of resources for the nurse leader throughout their growth from novice to expert. The link considers the need for project management threaded in all aspects of being a nurse leader. We do not know of any competitors that offer 4 modules in one platform. While we know organizations such as the Fold Institute offer contracted advising, we offer different levels of access to ensure all organizations have an opportunity to access resources and materials to support them, allowing for options that work with an organization as they continue to grow. Our customers are directors like Dawn, looking for structured training options for their nurse leaders. Current and future nurse leaders, such as Kim, would be our end users. With structured training through use of the modules, Kim will benefit from leadership, professional development, and understanding how to lead a project. The measurable outcomes that can be achieved by Kim being better equipped to lead projects would be improved patient care outcomes in nursing sensitive indicators and patient satisfaction. Use of the modules in the link can also achieve measurable outcomes such as improved nurse leader satisfaction and increased retention.
The year one budget focus is focused on establishing the link platform. Our request is just over $82,000. Looking at year 2 and 3, our focus is on sustainment, maintenance, and promotion, and that's an average about $26,500 per year. This would allow us to continue our help desk capabilities, have our licensing and consultation fees covered. Looking at our revenue projections, we know from our national dissemination of our HARP Leadership Development Program, we had over 12 organizations reach out for that curriculum. If half of those did the $500 a month subscription of HARP only, that would equate to $36,000 per year that could be reinvested into the link. Looking at our detailed budget, the majority of the cost is on our technology build of the link platform. We're also asking about 12% of the budget to be dedicated to labor using intern resources for implementation specialists and help desk. Sustainability is very important for the link. The first is to create in-kind support and continue what we've already been doing with our sub-programs of the link. Our organization is committed to having leaders support, continue to maintain and grow and develop the link. Next, we look at creating connections with professionals and professional organizations, looking to have volunteer opportunities to coach, mentor, and support as part of the link. Next, we have our community. We believe that we'd be able to create a link community that as it continues to grow, it would reinvest and add resources into the link. Finally, the implementation team would focus on feedback on how we would be able to incorporate continuous improvement in the link.
We have a dynamic interprofessional link team that includes the creators of HARP, who authored an article that was published in Nurse Leader, listed in the AONL Workforce Compendium, and presented locally and nationally at conferences. Dawn was able to get funding for the Project Support Center and HARP self-service implementation options through the link. Kim participated in the HARP Leadership Development Curriculum and accessed the Project Support Center to complete projects on her unit. Kim's satisfaction in her job increased and she felt less burnout. Dawn is grateful for the tools offered that she could share with Kim and her other managers, allowing her to better support them. Like Kim and Dawn, tens of thousands of nurse leaders from across the U.S. would benefit from the link and feel equipped, engaged, and empowered. Hospitals would save money and patient care would improve. Nurse leader retention would also increase. Thank you for your time, and here are our references should you need them.
Well done, right on time. Thank you.
Thank you.
All right, thank you all. So questions, Michael?
Mute.
Sorry. I greatly enjoyed your talk, and I also noted the trend in hospitals for charging for services like IRB and the like. What has concerned me in that model has been, how do you select for safety net hospital versus rich private hospitals versus academic medical centers or VA hospitals? It seemed to me to be a funding that might select only hospitals who could afford you.
That's why we have various tiers of access. So we have a free resource option that has downloadable PDFs that institutions across the country would have access to. Our goal is truly to be able to help as many nurse leaders out there as possible.
Thank you.
Katie.
Thank you. Great presentation. My question is, how do you adjust to, because when you talk about nurse leaders, it's a big bucket, right? And various levels of leadership, with starting at, someone very close to the bedside to the boardroom, right? So how do you adjust what you're offering to all these various types of leaders? And then second, it seems like most of your product is focused on project management skill building. And how do you connect that to what the measures you opened with in terms of improving retention? Because I'm trying to make that connection to, because we know we're not short of tools. We're short of time to use the tools. So just bridge that for me, if you don't mind.
Thank you for that question. For the first part, we have developed the 4 different modules in the link to help to make appropriate connections for each level of leadership. And for example, in our HARP leadership development, we have facilitated that program with frontline managers, directors, and it continues to grow up the chain of leadership. The second component is based on research. We've found that nurse managers are struggling with balancing both the day-to-day operations and the special projects that they're being tasked with. So we highlighted the Project Management Support Center because it does include tools and templates and how-tos and examples, but it has a component of having a reach out to a project manager asynchronously for the subscription, self-implementation, and for the free resources, and being able to really look at how do we connect those resources so that nurse managers can learn and practice project management so that it doesn't feel like an addition to their already busy jobs.
Risa,
And I can attest to that.
Risa, you had a hand up. I'm not sure if you still have a question.
Yes, I do have a question. And it's a combination between our first and second judges. So my concern, and correct me if I'm wrong, it seems like you have a free toolkit from the very beginning, and it seems like that caters to only the beginner leaders out there. So usually the problems are the beginners and also those people that have been in the workforce as leaders for a long time because they're stuck and they have no way moving forward. So how do you propose for them to avail of this project knowing that there's a fee to it and not a lot of people can afford $500?
So I think that the free resources, they are resources, but they are still set up in a way that it kind of teaches, shows how it's done, and then you're able to then try it out. And you can always submit, we talked about help desk, but part of it is we envision having an Ask a Project Manager section for any of the levels. So they could post a question, send a question to us, and we can help to answer their components. And then also we want to collaborate with those professional organizations who offer continuing education for those professionals who volunteer their time, such as the Project Management Institute. If a Project Management Institute volunteers their time, they're able to get continuing education credits so that we'd be able to leverage that component to support more and more people who need that help.
Great. We have time, I think, for one more question from our judges. If not, we can move on. But do any of the other panelists have questions for this team? Katie?
I can ask another. So help me connect this also to nurse leader well-being, because we know that's a major issue right now for nurse leaders. The toughest jobs, toughest job for a leader right now is being in that nurse manager role. So do you see any connection what you have here to addressing nurse leader well-being?
100%. I am a nurse manager that has gone through the HARP curriculum, and it has given me tools to be able to have crucial conversations with my employees, how to present, how to start a project. It has given me the tools that I needed that I think is a structured training format that is not available in many hospitals. A lot of us nurse managers learn from other nurse managers. So our idea is really to provide that structured training that would be feasible and not something that has to be reinvented in multiple facilities.
And then to build on that, our HARP leadership development, for example, we do wellness hour each month. We give wellness resources at our organization. We actually have a wellness SharePoint site that people can go to get resources. And then we also measure that using a thriving scale so that we can check level of burnout and be able to readjust as needed based on what is happening with our participants at that time. And then we've actually seen in the HARP program specifically a decrease in nurse manager burnout as they progress through that module.
Great. We are out of time. Thank you very much. Next up, we have the Montefiore Einstein team.
And for our judges, that's application 387, Montefiore Una.
Good afternoon, and thank you all for having us here today. We're very privileged to be finalists. Dr. Catherine DiPaolo and myself, Dr. Una Hopkins, are going to take you on a journey on transitional care excellence. We are going to take you to the Bronx, New York, where we are and care for the sickest and poorest patients with multi-problems in the complexity world of medicine. And in the US today, we have lots of patients like Mr. M that you're about to meet. Mr. M, between June and September, had 14 hospitalizations and ED visits for COPD. Each time he was hospitalized, he was discharged with follow-up instructions and inhalers. However, he couldn't stay out of the hospital. He needed more. He needed a personalized care team. He needed medication adherence monitoring and a person to call other than the ED. We needed to create health equity for Mr. M. So what does a readmission mean and who does it impact? Well, it impacts the patient with frustration and hopelessness. It impacts the family with concern and burden and worry. It impacts the nurse with anxiety and distress after discharging this patient only to have the patient come back to the hospital. And of course, the hospital system has multi-penalties and its reputation to look at. Reducing 30-day readmissions are a healthcare priority around the world. Value-based programs utilize this 30-day readmission as a proxy metric for transitional care quality across the continuum of care. I'm going to let Dr. DiPaolo take you through our journey.
Thank you, Dr. Hopkins. Our traditional care models in this space either are hospital-based or in the ambulatory space, and they really focus on just one reason for being in the hospital. They're not designed to provide the level of continuity for our medically complex and socially vulnerable adults. Our transitional care excellence model leverages multidisciplinary team that is led by nurse practitioners who see patients both in the hospital and longitudinally in that 30-day post-acute window to really optimize their journey from hospital to home and make sure that they have everything that they need. The pillars of our model focus on pharmacoequity, making sure that our patients have access to the best medications that are going to improve morbidity and mortality, social determinants of health, and plugging patients into community-based resources. Having our hospital-based clinicians see their patients via telemedicine at home with that personal touch, and of course, wellness, as self-care and mental health can really improve health outcomes. We want to layer onto this existing model technology because we want to use this to automate some of the processes to get data from our patients so that our nurse practitioners can practice at the top of their license so that they can work smarter and not harder and do what they do best, which is care for patients. Our patient-centered technology-powered next practice will make us better than best. While there's other companies in this space that can either use AI, virtual assistants, or IVR, or even virtual therapy management to automate some of these processes, they all lack that personal touch. And they're very much hypothesis generating in terms of can they reduce readmission rates? We know from the evidence that nursing-led programs do indeed move the needle of readmission and our best care. This is why 60% of our budget is allocated to technology that can be used for our patients that at this time is currently not, the devices themselves, accessible to our patients. We're 85% Medicare, Medicaid in the Bronx, so it's very challenging for our patients to buy smartwatches and wearables. But we can leverage the data that we get from this technology to bill from remote patient monitoring and remote therapy monitoring. That revenue generated from our nurse practitioner billing, in addition to the reduction in financial penalties, is going to fund our program and sustain it past year one. Why this model? Well, we know transitional care. Our previous work in heart failure has turned us from one of the worst performers in 30-day readmissions to better than our peers. We've been able to reduce our 30-day readmission rate for heart failure from over $700,000 in a penalty to, for the first time in fiscal year 24, no penalty. Our goal is to take this model, to power it by technology, and expand to other high-risk disease states like heart attack, pneumonia, and COPD. We've committed to this transitional care excellence model, and we have the structure already in place with executive leadership support and nursing leadership support from the entire care continuum. We've already dedicated 17 new positions, nurse practitioners with medication expertise and the ability to navigate on behalf of our patients to provide that excellent care. And we've recruited this team that is diverse and inclusive. They mirror the community that Montefiore serves. Our NPs have over 70 years of combined experience in specialty practices, as well as hospital medicine and ambulatory care.
So how do we measure success here? Mr. M's future state, our nurse practitioner identifies social determinants of health and suboptimal clinical care as drivers for his hospitalization. They optimize his medications, provide him with a prepaid phone and smart inhalers, and he has direct access to his care providers. We will evaluate this technology through a quasi-experiment. One hospital will have tech plus team, the other hospital will have team only, and Montefiore scales the model to bridge the digital divide in care equity. So our people-led, technology-driven transitional care excellence transforms care delivery. Mr. M and all other patients and family deserve this kind of care. We are people-led and technology-driven. Our next practice can help systems achieve the quintuple aim of improved patient experience, better outcomes, lower costs, clinician well-being, and health equity. Thank you for your time this afternoon.
Thank you. Right on time. All right. Questions, Robin?
I have two. I'll be real brief. First one is, could you speak a little bit to the clinician well-being component? How do you intend to measure that? And the second is, from the technology perspective, with the diversity of your population, are there provisions for different? Obviously, speaking different languages is what you're using currently. How will technology be adapted for different languages? Thank you.
Well, thank you very much, Robin, for that question. We're going to do that in a two-part series. I'll take the nursing well-being, and Catherine will take on the technology pieces. So nursing well-being has been a very, very important part of Montefiore, and we have lots of systems in place. We're using lots of tools, and we have a wellness initiative going on, and we will measure it through that.
And from the technology side, so we want to meet patients where they are, and we want to start to, bridge the digital divide. So patients it may be as simple as providing them a mobile phone and doing a good old-fashioned telephone call. It could be we have devices and we have partners within the community that have cellular-powered video visits that we could leverage that technology so our clinicians come into the home. Our clinicians themselves, our nurse practitioners, again, are mirroring the community that they serve, and we try and really match our patients with clinicians who, speak their language in every way and shape of that. Yeah.
Great. Kate?
Are you saying Catherine or Katie?
Catherine, go ahead.
I'll go ahead just real quickly, just so I understand appropriately. Sounds like you have you've had a good historical platform in which you really impacted your CHF patients. So this project really is just layering on, but layering on the technology that you believe is needed to impact pneumonia and COPD. To impact readmissions. Did you use any technology with your cardiovascular patients?
We had some remote patient monitoring that was limited to hypertension, but the digital divide is real here. Getting our patients access to that, getting them access to Bluetooth scales when payers are not reimbursing for the devices has limited it. And we also want to use some of the technology to automate these processes, which really relates to the clinician well-being. My nurse practitioners will be on the phone for 2 hours and continually, try to call a patient because they know that that is what is needed to get out of the hospital. But if we can automate some of those processes, it will really allow our team of 17 to have the, breadth and depth to see the volume of patients that we have here in Montefiore, which is thousands who are coming in for acute on chronic disease.
Great. Richard.
Yes, major impact on ambulatory care well-being is electronic health record and MyChart messaging, which is just overflowing ability to respond. How are you going to manage adding yet another messaging portal or context for high risk, high volume patients and well-being of the nurses that are addressing these issues?
That's a great question, and we do not want to duplicate. We want to always kind of be meeting patients where they're at. If they're well plugged into MyChart, we use MyChart currently, and that's our primary go-to. This would really supplement for patients who do not have the access to, do not have the smartphones, do not have the computers. So the tech piece of our solution ranges again back from mobile phones, which could be the game changer, to just making sure we leverage MyChart and then integrate RPM, daily weights, medication adherence data, and have that kind of come through the flow sheets and use MyChart as the route of communication.
It's helping our clinicians to be more efficient in their activities.
Great. Michael?
I greatly enjoyed your presentation, and I think you touched on a very important aspect in medicine. We know that one of the major drivers of burnout is when a nurse knows what their patients need, but they're unable to deliver it. And so I was concerned that many of the things that patients need, when I looked at your budget, smart pill boxes, smart inhalers, remote spirometry, are not covered by any insurance plan that I'm aware of. And how do you foresee managing these critical tools that you're talking about?
It really requires that kind of upfront investment so that we can get these devices. And then from the devices, we will layer that RPM and RTM billing into the transitional care management visits that our NPs already conduct. So we see our patients, the same clinician, the same NP who was in the hospital with the patient, follows up with them 7 or 14 days after discharge. We bill for that visit. If we pay out of pocket for the device that's not covered, well, then we can add the data that we're getting from it into our visit, and it will be able to sustain that. We're also hoping that this model can bring, innovation to CMS and start to change policy around this, because we need this. We need Medicare and Medicaid to start paying for more of these technologies as we get the data that shows that they do indeed improve outcomes.
Health equity.
And health equity.
Thank you very much.
Thank you very much. You're welcome.
Marion, you're on mute.
Riza, go ahead. We have about 1 minute for a response after your question.
Okay, so it's on sustainability is my question. I love your topic. I love your idea. I'm a nurse practitioner too, and I see a lot of readmissions. My concern is, each time someone develops something based on technology, my workload increases. So are you envisioning something that also, your nurse practitioner's workload would increase, especially when you mention direct access to nurse practitioner? I love it that they have direct access because I love my patients, but that would just mean if that's me, I will have more phone calls or email to answer or what have you at the end of the day.
Yeah, I think, you know, that because it's a personalized model and technology is used to support it, it's the people model that's really important. And when you only have a finite number, and we've heard today how difficult the nursing workforce is, you have a finite number of nurses, you need to support them with whatever technology you can. And so having data come through before your actual telephone visit, you have more data to be able to utilize as if you were going to pick up and look at a lab before you call the patient. So you're going to have more data, and it will make your visit smoother and faster and more efficient.
Right, absolutely.
Right,
And it
absolutely. And it may
avoid some additional utilization. So instead of sending a patient to get labs, we have them in the home and it takes, you know, that would be 2 NP visits where they would need to follow up. It then becomes 1.
Great, thank you very much. All right, so next up we have the Universidad de Estado de Santa Catarina.
And for our judges, that is application 381, UDESC Joanna. And again, judges, we kindly request you finalize your scoring within the open water application. And if you have any questions, please feel free to reach out to me directly. Thank you.
Hello, are you seeing my screen yet?
Yes.
Thank you so much. Can I start? Yes. So, hello from Brazil. I'm Johanna, and I'm speaking for Team UDESC. So I want to introduce you to Nurse Mary. She's an amazing nurse, but feels unseen, unappreciated. Yesterday, she saw a colleague take credit for something that she did. And today, one patient said that she was so intelligent, he thinks she was a physician. Mary started the question if she should continue to develop her path in nursing or to pursue another one. And the fact is that Mary is not the only one making herself that question. Around the world, we are facing a crescent intention to leave and turn over as our entities already identify. Nurses are tired of being unseen and tired about people don't know what we do, who we are. Brazilian population relies on nursing care, so this is a significant problem. Add to that the possibility for violence or harassment in workplaces, and you have a professional in the edge. So the question is, how can we promote a feeling of belonging, appreciation, and retention of nursing care setting? For this, our solution is Inside Nursing, a nursing awareness campaign produced by nurses for nurses. When you enter a common area of a teaching hospital, you will see 4 displays, 5 to 6 feet tall, and on that we'll be playing videos showing aspects of nurses' lives, of their works, and patient stories of the impact that nurses on their lives. Aside that, people will find a QR code that will direct them to a profile on Instagram where they could find more stories and ways to engage on Inside Nursing. Also, we'll have posters on corridors of the same teaching hospitals with showing activities of nurses within a box filled with postcards, giving the opportunity to patients and also for colleagues to send their appreciation to nurses in other nursing care settings around the south region of Brazil. These boxes will also be available on patients' rooms. So Inside Nursing will take place, as I said before, in 3 teaching hospitals located on capitals of states in south region of Brazil. It will be, to develop this campaign, a process on 3 steps: plan, train, and do. In plan, we'll hire services, prepare organizations for launching, and produce an online course about digital content production for nurses. In train, we will prepare these nurses to script, produce, edit, and share digital content Inside Nursing. And in do, We will launch on International Nurses Day, maintain production, maintain a social media, and organize it to expand not just for hospitals, but also for primary care setting and other organizations. Well, you could ask yourself, a campaign again, really, Joanna? So this is different for three main reasons. One, focus on humanization, who we are, what we do, and the impact of that on patients' lives, bringing humanization to the traditional warrior, hero, or simple caregiver archetypes so used in communication about nurses. Two, nurses on screen that really works there. And three, scripts and stories chosen by nurses, giving the chance for them to control their own narratives. Our partners also could be our customers, especially nurses and nursing entities, because since the campaign could bring visibility not just for the nurses, but for the organizations, an example as EPSER and CONASEMS, and another private healthcare facilities could use inside nursing strategy to promote nurses and their own organizations. For inside nursing, we requested $94,000 in first year for equipment, salary, travel, and miscellaneous. This last detailed on my next slides. And to keep inside nursing on years 2 and 3 and going on, we will need $20,000 per year, referring specifically to work hours for professors and for nurses involved in this strategy. This is our budget, and miscellaneous especially will be spent on digital course content and video production, branding, and marketing for launch the campaign. So the biggest part of the resources will be used on the plan phase. And salary will be for a nurse that will be help on establishing the campaign in the first years and also to set basis for expansion. The team will be with professors and students, and we also will have, they also had a partnership with these organizations. And the sustainability will be maintained because UDESC want to maintain inside nursing as a permanent campaign. And for that solution, will be held this campaign inside our nursing master program, and we will dedicate a student to be holding the campaign with us. And we will intend to that establish a partnership with City House and bigger partnerships to collect and disseminate postcards. We are intention here. So imagine Mary coming to work and see herself on screen on a video that she recorded and edited. Imagine Mary receiving a postcard for a patient that she helped to come back to their loved ones. Make nurses feel good because it's so simple, but also is powerful, humane, integrated, and sustainable because it's made by nurses for nurses. Thank you so much.
Well done.
Well done, right on time.
All right, judges, do we have questions? Riza. Riza, you might be on mute.
So sorry. So I love your idea. You're humanizing nursing. My question is on protecting patients' privacy, since if I understand it correctly, you are inviting patients and family to the sharing story platform.
Yes, of course. We will invite them to share their stories, and of course, we will share with them a term of consentment and giving them the opportunity to share their stories if they want. It will be not mandatory, of course. It will be terms of disclosures, and we'll be writing them and inviting them to join in our campaign if they want.
Great. Richard.
Thank you very much for the presentation. There are many types of appreciative inquiry practices. Gratitude is one of those practices. Help me understand why you chose gratitude as having an influence or major influence on your outcomes.
Yes, of course. We identified through a lot of researches that nurses feel that people don't value what they do and also don't know about what type of work nurses do in Brazil. I don't know if this is a thing that happens in United States, for example. It's very common that patients confuse nurses by physicians or confuse nurse technicians with registered nurses. So there's a lot of bad things that nurses feel inside their day-by-day job. So we want to make them know that they are seen, they are valued, and the things they do matter so much for patients and for their families and also for their colleagues and for everybody involved in the work they do.
Great. Any other questions? Katie, go ahead.
I have a question, and again, great presentation, and I love the human element with nursing, particularly since a lot of what we do has become so task-oriented, and it's really good to see that you're making a difference. My question is, I'm comparing your program to something we have in the US called Caring Bridge that, does similar things, where patients put information and nurses, but I don't think it's set up to what you're building where nurses get to see it. And that's what I'm still trying to understand, not to mention what measures of success specifically have you set up to know the effectiveness of this program?
Well, we wanted to apply 2 scales, and we are imagine that we will need to use also another measure to identify the brand impact of nursing in the collective impression for the patient. So we are setting to apply the turnover intention scale and the job crafting questionnaire before and after our intervention in the prototype phase in the 3 teaching hospitals. And also we will need to identify a way to measure if they imagine that patients and colleagues and the feel of the brand nursing it changed before our campaign and our intervention. So it will be this 3 type of things, 2 scales we already identified, and the third one we will need to study a little bit more in the course of the plan phase.
Thank you. Thank you.
Great. Any final questions? All right, thank you. Next up is the Duke Health System. So we have this team and then one more team, the Vancouver Coastal Health, and then we will have a 5-minute break. So we're almost to a break.
And for our judges, that's application 375, Duke Kimberly.
All right. We are Dever AI Innovations, and we're excited to introduce the future of workplace safety. This is Ursula's story. I was a newer nurse working on a 36-bed telemetry floor, taking care of an overflow psych patient. One night, I noticed my patient on the floor, crouching in the corner of their room. I went in to find out what was wrong, and that's when the patient ended up using my own stethoscope to strangle me. The patient then punched me multiple times on my head, face, and body, and fractured my elbow. I wasn't given the tools or the practice to recognize and de-escalate aggressive patients. Current training methods fail to prepare nurses in preventing workplace violence. The problem is workplace violence has significantly increased the last few years, warranting new regulatory requirements for prevention. The problem is 82% of nurses have experienced workplace violence in the past year. The problem is workplace violence alone costs hospitals $206 million per year. The problem? Okay, to be honest, this redundancy, it's been intentional. 30 seconds in, I'm sure you're tired of hearing it. 3 years in as a nurse, I'm positive I'm tired of experiencing it. But what if I told you there is a solution for this? Well, here it is. Our solution combines the immersive power of VR and the intelligence of AI to revolutionize workplace violence prevention training. So, imagine being a nurse, walking into a room, and you're instantly faced with an aggressive patient. It's tense, it's unpredictable, and every word you say and move you make matters. Now, what if you could train for these intense moments before they actually happen? What if you had a chance to refine your approach in a safe environment? Well, that's where our solution comes in. Dever AI Innovations is an expansive library of VR modules with various patient scenarios that will teach nurses how to verbally de-escalate aggressive patients before they become violent. The nurse will be interacting with an AI patient that responds in real time to the nurse's actions and words. And my favorite part, thanks to our proprietary IntelliFeedback system, as the nurse interacts, it offers AI-powered guidance, transforming each scenario into a live coaching session. It's hands-on learning minus the real-world risks. Because, let's face it, stuff like this is learned best through experience. So, it's important to recognize we're not the first to tackle this issue. But why are we the best? There's no other solution that offers the consistency and customization of our AI-powered patients. None that offer the personalized performance feedback or granular data insights that our post-training analysis provides. And we are the only one that offers real-time iterative learning with our IntelliFeedback system.
There are many phenomenal outcomes that can come from this solution. On the right, we've highlighted 3 that will provide both quantitative and qualitative measures for evaluating its impact based on our current state and implementation plan. Our short-term goal is for 90% of our VR AI trained nurses to report improved confidence in preventing workplace violence within that first 6 months of launch. This will be achieved by incorporating feedback from our nurses in high-risk areas piloting our MVP, emergency department, general medicine, and pediatric step-down units across 3 hospitals. As we expand in other clinical settings, we expect to see education compliance increase by 20% within 9 months. And with greater access and refinement, we will meet our long-term goal to reduce nurse workplace violence events by 10% in the next year. This slide shows the potential market for this product expands well beyond Duke nurses to the 22 million U.S. healthcare workers vulnerable to experiencing workplace violence. Our solution is not just a nice to have, it has real value that can be captured. We calculate an annual cost savings of $827,000 gained by reducing nurse training time from a 4-hour class to a 1-hour personalized session. 20-hour access to training resources means nurses can practice their skills on the unit to build confidence, and we can bolster education compliance. Accounting for potential impact on days away from work due to workplace violence injury and turnover yields an additional $153 million saved in avoidable costs. So over the next 6 to 12 months, we'll be working with our administration to implement within our hospital nursing workforce. Then we'll roll out to all disciplines that interact with patients in our entire healthcare system, such as physicians and hospitality staff. Next, we'll market our content and modules to other healthcare systems through subscription-based enterprise licensing. We're asking for $150,000 to develop this innovation. You'll see our budget exceeds that, but we have executive and other funding support to cover the difference. Year 1 is allocated towards startup costs like VR equipment, VR content creation, and the integration of our customized AI model. Looking ahead to years 2 and 3, our budget emphasizes scaling and expanding our impact, including wider healthcare system implementation and market expansion. This slide shows how we will leverage our current channels to take this innovation from lab to market. We've already engaged stakeholders and connected them to VR technologists to develop content driven by actual workplace violent event data. As we're kicking off our pilot, we have the executive and operational support to drive change and accountability, and our technology infrastructure will help us test and improve our MVP. And we're securing additional funding from our Duke Institute of Healthcare Innovation. These are our additional team members that are collaborating with us to bring our innovation to life. So what's it worth to prevent workplace violence? How much better could nursing care be when nurses feel confident and safe to practice? And how many nurses could we prevent from leaving healthcare? How many healthcare dollars could be saved from missed work, medical bills, and therapy costs due to workplace violence events? So the only question we have left is, are you ready to join the Dever AI revolution and prevent workplace violence? Thank you.
Well done. 10 seconds to spare.
All right, first question, Catherine.
Yes, well, first of all, I always want to state I am really sorry you have had to experience workplace violence. No one should have to do that. My question again is related to the content build. Are you using a proprietary or an evidence-based program regarding the build into this training program? And then number two, what do you do with those who really have vertigo when they're in a VR training environment?
Yes, regarding the actual content, we're using evidence-based approaches informed by, recent like behavioral health science and also, so basically, as far as like the response, we're, rooting it on developing trust. The goal is like trust, and also the trust, and then physiological needs as evidenced by our Maslow hierarchy of needs, and also safety. So those are the goals for the response. And and we're using basically.
Yeah, and so
go ahead.
Good.
For the second part, our modules will be developed with cross-platform compatibility, which will allow them to be played on both VR headsets and traditional desktop computers. So this dual modality approach will ensure a wider reach and can cater to individuals who experience the common VR-related issues, like the motion sickness that you mentioned.
Great, Michael.
So first, you're addressing a horrible circumstance in hospital care now. It's so common, it's almost like workplace violence is part of the job description. And so addressing it is critically important. I love the idea of teaching and de-escalation, but what troubles me is whenever we have programs that are made for the victims and making it not part of a program where we're addressing the causes. And so as part of this, is this coupled with any of the strategies that are designed to decrease workplace violence by the perpetrators? And I don't mean only the psychiatric patients, but the other verbal and other violence that nurses are suffering with today.
Yeah, so you brought up a really great point. So the nature of healthcare, especially in these high stress areas, like you mentioned, will always have its inherent challenges. And given the unpredictable nature of human behavior and a multitude of external factors at play, it's highly unlikely any solution will ever entirely eliminate this problem. However, our solution will equip and empower staff with the tools and techniques to handle these situations more effectively than the current training methods that are available. So our aim is to significantly reduce the frequency and the severity of these incidences and enhance staff confidence in managing those situations. So the real value in our solution lies in proactively equipping our staff, thus enhancing their safety and the overall quality of care that we can provide.
And part of it too is also thinking about our sustainability, our partnerships with a lot of our centers. We have some excellent facilities here at Duke that focus on the aging and also autism spectrum disorder. And so we'll be partnering with them to tailor and customize some of these training modules to help staff better identify different behaviors associated with some of these higher risk groups, and also to know how to appropriately handle it so that both the patient feels safe and comfortable and the staff feel confident in being safe as well.
Richard?
Just quickly, I've been a psychiatric nurse for a really long time, so I am intimately familiar in working with workplace violence and having teams highly trained. to address workplace violence. And so my concern is, and it's playing off of Michael's question, is there anything within your module where you're going to train managers and leaders in the system to look at policies, procedures, and responses to workplace violence so that the nurse is not left hanging? So it's one thing to train, but it's other, what is there a systems element to your approach?
Yes, absolutely. We currently function off of our safety reporting system, which all of our nurse managers are currently looking at daily, honestly, every 4 hours of any type of workplace violence, and are learning from each and every incident that our staff are putting in. So that keeps the focus directly on the frontline staff, while our nurse managers can react to those SRS reports or safety reporting system reports that are put in. We also have current teams in place that are reacting sort of like a debrief with every single reaction that we have in any area throughout our 3 hospitals.
Yeah, and honestly, I am a psychiatrist, I worked as a psychiatric nurse, and I manage a behavioral health, like education and training program for the health system. And for the past 4 years, we've implemented like the Joint Commission mandate on preventing workplace violence. And we have a comprehensive health system approach, focused on workplace violence to train leadership, security staff, every level of anyone who interacts with patients. So this is just part of another piece of that, to leverage technology to access, increase access. So,
and I'll just tag on. Go ahead. This technology allows us to really gather some very deep and meaningful data to help our organization with the direction. So like you said, to inform our policies and changes and which areas that need focus, which roles, those kind of things. So it's very comprehensive and built within our current infrastructure. We've got the great committees.
All right, so the final question from Robin.
Well, and I think you answered my question. So, I was going to ask if this technology, which is this is a creative use of virtual reality, is a component of a larger, training plan, or if it's just a one-off intended to be, kind of a one-to-one in isolation of a bigger plan. But you answered that, so thank you.
Just to add to that,
Go ahead.
This is ongoing for 4 years. So we're not stopping. This is gonna go on, and sustainability is really our focus on this.
Great, thank you all. Next up, we have Vancouver Coastal Health.
Just gonna share my slides. Hey, can you guys see my slide?
Yes.
Yes? Okay. Yes, okay. Hi, I'm Sally, the nurse lead for AutoChart. What if I told you that nurses fill in 150 to 300 data fields in nursing spreadsheets for every patient, and that this translates into at least 1 hour of charting per shift, with some units such as the ICU spending up to 4 hours? I want to tell you the story of Monica the nurse and Nick the patient. Monica's unit is short-staffed, and she has 6 patients. By the time Monica finishes her assessments and provides basic nursing care, she's slammed for new orders, discharges a patient, and admits another. Sound familiar? There is no time. Although Monica knows charting is crucial for communication and legality, it's often neglected due to imminent patient needs. Finally, when Monica sits down to chart, she takes 2.5 hours because she's had 7 patients in total throughout her shift. During this time, she's taken away from the bedside and does not check up on her patient Nick. Due to late charting, the doctor is not aware of his weight gain from fluid retention and doesn't increase his diuretics. Nick goes into respiratory failure and is transferred back to the ICU. So what is the problem here? Nurses are burdened with tedious charting that causes fragmented workflow and inefficiency, resulting in prolonged charting, time spent away from patients, resulting in poor quality care and safety events, late charting that impairs team communication, resulting in non-timely treatment and poor patient outcomes. And finally, charting in tedious boxes causes burnout, not just because it's a painstaking task, but because nurses hate to be charting instead of being with their patients. The moral distress of prioritizing documentation over providing quality care is a significant burden to carry. In fact, Monica leaves bedside nursing after 2 years because she is not supported with sufficient technology. Nurses have long been excluded from dictation service innovations and need to have a voice in creating this technology. We propose our novel nursing documentation AI called AutoChart. Using AutoChart, the nurse can verbalize their assessment in real time using a mobile app or desktop software. This is then transcribed offline into a text transcript. AutoChart then analyzes the text transcript by undergoing natural language data extraction. As seen on the right-hand side, this assessment data is then classified into EMR assessment fields. Finally, this is sent to EMRs like Cerner to be uploaded. The nurse can also review and verbalize any additional assessment data to the EMR after. AutoChart can also analyze recordings and automatically create nursing-specific handover information, as well as provide shift summary reports. We are not like any other transcription service because we aim to serve nurses. Other transcription services have focused on physicians as their client and have only produced narrative notes. No other service extracts assessment data from nursing speech and auto-populates into nursing flow sheets. In addition, no other service has utilized nursing assessment speech to generate an SBAR or fill in a handover tool. And we are not imaginary. We recruited 13 nurses and produced 65 unique nursing assessments. Based on these 65 recorded assessments, speech-to-text was 90% accurate in transcription, and NLP AI was 95% accurate in interpreting and classifying assessment data. So what is our impact? AutoChart will revolutionize nursing documentation for every nurse using an electronic medical record. And by reducing documentation times by 75%, 45 minutes to 4 extra hours will be available for each nurse per shift. And if we translate that time saved into money, that's $4.5 million to $21 million per 950-bed hospital per year. This extra time allows for delivering higher quality care, which can prevent outcomes like pressure ulcers, falls, and other safety events that cost hospitals worldwide billions. We expect that these improvements will lead to decreased nursing burnout and increased staffing retention. AutoChart would also allow to safely increase patient loads when necessary and survive the current nursing shortage. By setting a precedent for technological adoption, we contribute to a larger movement towards a more efficient and effective healthcare ecosystem, which values nursing innovation. Our customer is targeted to any health system using electronic charting. However, we are beginning with Vancouver and Providence Healthcare, which uses Cerner. And if all BC's 8,620 acute care beds used AutoChart, they would save up to $67 million to $283 million in market value in just 1 year. Imagine the impact we could have if used globally. It's difficult to measure the nurse retention that AutoChart will cause, but certainly the availability of technology to mitigate manual charting will reduce nurse burnout and increase nursing retention. We know that health systems prioritize cost savings over cost avoidance, but BC spent $181 million on nursing overtime alone in 2014. And from personal experience, a significant amount of overtime is accrued from finishing charting after a shift or paying an additional workload nurse to come in. Investing in AutoChart would decrease expensive travel nurse replacements and OT. Here's our financial breakdown for year 1, where we aim to meet the goal of building a working product and trialing it on a 24-bed unit for 3 months. Most of our costs in this first year will be spent on software development, integration, and security. This is our second year financial budget, where we aim to continue validating and bringing AutoChart to market to gather clients. We are eligible for the Microsoft Azure startup credit of $150,000 and have identified other sources of funding, including our local health authority ventures with opportunities of over $200,000. To evaluate AutoChart and ensure we're meeting the 75% reduction in time savings, I would conduct a study with the University of British Columbia under the supervision of Dr. Leanne Curry to analyze outcome measures such as efficiency, user satisfaction, patient satisfaction, as well as cost savings before and after the implementation of AutoChart. Our team is truly interdisciplinary and contains the expertise to implement AutoChart. We are comprised of experienced nurse leads, researchers, physician leads, a PhD expert in AI and software development, a senior director of nurse informatics, and a Vancouver Coastal Health implementation lead. We are partnered with 3 local health authorities, Vancouver Coastal Health, Providence Health, and provincial health authorities. Specifically, we are supported by Natasha, the CNIO of PHSA, Dr. Guan, the Director of Urology at VCH, and Dr. Rachel Ritchie, the Director of Innovation at VCH. We have also been supported by the UBC Clinical Informatics Professor, Dr. Leanne Curry, to oversee and advise the project and the study evaluation. Internationally, we are also partnered with CNO from MUSC, Trish Gallagher, regarding future partnerships and bringing our idea into reality. I'm going to leave you with thinking about what Monica and Nick's story could have been. Imagine a world where Monica's weight assessment was automatically input in real time and Nick received diuretic treatment on time. Imagine how Monica's workload would be eased. And imagine Monica never leaves bedside because she's supported by technology and her concerns are heard. AutoChart. We listen to the voices of nurses. Thank you.
Thank you. Right on time. All right. Judges. Sorry, I'm just trying to pull up whose hands are up. Okay, Catherine.
Yes.
Yes.
Well, it sounds like there's a echo. So my question is related to your competitors. I mean, I know the biggies like Nuance, and many of them have been working on this for a while. Actually, we piloted this a couple years ago. So what makes you think you can do this? I mean, it's everyone, we need to get here. This is one of the holy grails, and maybe even not voice activated. It's just observation. So what is unique about AutoChart and your capability that you think you can do this?
Well, I think that our team's expertise and the support that we have with our health authorities will allow us to leverage the benefits of a startup company. We can bring this to market faster than those companies will, and we can bring it cheaper. I mean, Oracle is thinking about creating a digital health assistant. We're aware of this, but the question is, when will that actually come to Canada? Like, we're hoping to bring this to Canada, right? And at what cost? I don't think our health authorities have the money to expend this money on an ongoing basis to Oracle. And if you think about Nuance, I've talked to Nuance, and a few years ago, this was, pitched to them, and they said, we just don't want to do nursing documentation because we don't see a profit from it. So they're not nursing orientated. They're not for nurses. They're for profit. And Nuance itself, when I spoke to them, they said that this solution is at least 3 years down the road for the US and longer for Canada. And in addition to that, we see what the electronic medical records look like right now when they're developed by these big companies. They do not serve nurses. They are not designed for nurses. It is incredibly frustrating to see the products that come from these companies and feel like, we weren't really considered in the design process, and it ends up impacting patient care, nursing retention, and our satisfaction. And so, and in addition to this, we do have other sources of funding where we can hopefully bring this to market faster than those competitors will. That is the best opinion.
Katie.
Yeah, I don't know if you've been listening to my presentations lately, but this is one of the things that I've highlighted in my presentations around, the fact that it's 2023. And we still have the situation where nurses' assessments are done where nurses write it on a piece of paper or on their pant leg or on a paper towel, and it goes in the documentation system later. Because there's no way you can have one hand on the patient, one hand on your computer. So I just want to commend you for this. This is phenomenal. And what I love about this, which is what you just said, because that's what I've been hearing in your presentation, this is a for nurses by nurses product. And this is what we need. And this connects directly to what we've been talking about regarding the value of nursing, where the investments that need to be there for nursing are not necessarily there because nursing is not considered to be revenue generators, right? So on the other side, you have other groups that have dictation applications and things like that. Nurses don't. So this is phenomenal. Everything that you just said in response to what's in the market and how you can compare, how you can lift this is spot on. And I just want to commend you for this. I'm so excited about your work. So thank you.
Thank you so much. I really appreciate hearing that, because I feel like sometimes it can feel like there's just no hope, but I feel like if we make our voices heard and we have the support that we need, there's no reason that we can't compete with these other competitors, and there's still a big market to work with. So even if they produce these solutions as well, why can't ours also be in the running,
Yeah, absolutely. You've given me hope today, so thank you.
Robin.
Thank you. I echo Katie's sentiments. This is really something that would have such impact on our nursing staff, and the benefits to well-being are just incredible. if you're able to, to successfully implement. I guess the question I have is, as I look at the budget numbers, and being, a previous CNO at a healthcare system and knowing the dollars that technology consumes, I mean, do you feel like your numbers are realistic? Tech work just is so incredibly expensive,
Yes.
especially in the development of, as well as then the build. And, did you bend, like, how did, I just have some questions about methodology for how you came up with your, your budget.
We developed our budget somewhat in coordination with our health authority. We would have to do some outsourcing offline software developers to make it feasible within this budget. Our real goal is that we're able to get more funding for this project so that we can, design this faster as well. Like you're saying, like, to be transparent, is it really feasible to do all of this in $150,000? Probably not. We probably do need more funding. This is the very best case scenario. And in reality, we're probably needing more funding for this. But when we've had conversations with our executives from health authorities, they're also very supportive of this idea. They want to see us be able to get more funding for it. And so that is the best way I can answer your question, I think.
Okay. And you know what? Your lens is from a different country. So, there may be some differences there as well. Thank you.
All right. So I want to make sure we have time for a break. Katie, do you have a quick question or comment? Otherwise, go ahead.
Yeah, I just want to ask a quick question about whether how do you think you get the big players in EHR IT organizations, the big giants to play with you? That's the only other thing, because there has to be some integration there.
Yeah, so we're kind of EMR agnostic, but because Vancouver Coastal Health is working with Cerner, we initially thought about Cerner, but we've also thought about smaller EMR companies like Meditech. 3 of our authorities use Meditech, and they're trying to transition into Meditech Expanse. We could probably offer a pretty good value to Meditech, especially to help them compete with their other EMR markets. So I think just leveraging what we offer to these other EMRs is important. And the fact that even though this seems like a pretty obvious solution, some EMRs haven't really thought of this because they're not coming from a nursing documentation standpoint. So many people are focused on the physician documentation that they don't think about nursing documentation and what's really needed to integrate these solutions into EMRs. And so in working with different EMRs, I mean, most of them have an open API, so we can build this product without necessarily talking to them. If we build with Cerner, they do have a software open developer program that costs about $15,000 to $25,000, where they'll actually help you make those integrations. I think that Cerner right now is much more concerned with their transitions into Oracle and keeping their customers, that I don't know if they're necessarily devoting any resources to a project like this right now. Yeah.
All right. Thank you very much. Thank you to all of the teams who have gone so far. We're going to take a 7-minute break. And when we come back, Christiana Care, expanding virtual care delivery, you will be up first. Thank you all. Please come back in 7 minutes.
Are we all on mute?
No,
Robin. No, Robin.
You can unmute Robin if you want.
I have a question.
Who's it for, Robin?
Well, it's for the team. So I didn't know if it was appropriate to ask it and who else is.
Oh, everyone
is
on.
And
okay.
This is being recorded.
And we are being recorded. You want to hold off, Robin?
I'll hold off. Thank you. No, I'm good.
Yeah. Okay.
I'll hold off.
You're back.
I'm back, Nico. Kathleen.
Woohoo. Welcome back, everyone. For our judges, this is application 357, expanding by Michelle.
Are we ready to go?
Let's wait. We said 4:45 Eastern
Okay,
time, so let's
okay.
wait one more minute or however many seconds that is.
It's okay, Michelle. I'll start when you start the timer, okay?
Okay, thank you.
And I'll give you the 1 minute.
All right. Are we missing any judges before we start? If the judges can come on camera so we can make sure you're all ready. I actually can't see them all. Let's see. I think we're good. Okay, you can get started.
Okay, thank you so much all for having us. I am Michelle Collins, the Vice President for Nursing Excellence at Christiana Care, and we're here to present Expanding Virtual Care Delivery, Virtual Acute Care Nursing Implementation Success. Melanie?
Hi, my name is Melanie Reese. I'm a clinical nurse from a medical floor. I love being a bedside nurse, but last year I was ready to walk away from the bedside after 14 years. Short staffing, higher acuity, larger patient assignments left me feeling inadequate, and no matter how hard I worked, I felt like I was not able to give patients what they needed and the care they deserved. I knew something had to change. I was invited to be a part of the virtual acute care nursing pilot, which was initiated to relieve some of these stresses. The Christiana Care model was designed by clinical nurses to address nursing shortages, improve nursing workflows, and relieve documentation burden. In this model, we work in a dual role, some shifts virtually and some shifts at the bedside, and no additional full-time employees have been hired. Due to our successful outcomes, we expanded from 2 units, 49 beds, to 17 units and 500 beds in the span of 9 months. Since we completed that expansion in June, we've interacted with more than 10,000 patients. The problem that we have been addressing in this work is that the current nursing staffing model was not sustainable. New innovative care delivery models are necessary. There are technological solutions out there for virtual nursing that look promising, but they're not addressing the implementation and workflow aspect of this massive practice change. We see this as an opportunity to share what we have learned through trial and error and some blood, sweat, and tears since September of 2022. We can share our successful model that other healthcare organizations can utilize to impact their outcomes and take better care of their patients and their nurses. We have improved patient experience scores by 3 to 8 times across the board. We know that the utilization of the virtual acute care nursing model works. We're experienced nurses having one-on-one communication away from the chaos, bells, and demands at the bedside, and we're having these one-on-one moments of individualized care, and it has had a significant impact. You can see that these patient experience numbers have dramatically improved. We've also had organizational outcomes. We've seen a decrease in the readmission rate due to that one-on-one time educating and teaching back, ensuring patients are properly educated and ready to go home. We've seen a decreased length of stay as our virtual nurses are very involved with the interdisciplinary team, working on care coordination and making sure things are not getting missed and prioritizing timely discharges. Purchased labor has decreased by $60 million from fiscal year 2022 to fiscal year 2023, not exclusively because of the ACN program, but it has been a contributing factor. And it's worth mentioning again, we've done all this without hiring any new FTEs. Michelle.
Our solution includes creating a comprehensive content and services available via an external website for other organizations to capitalize on our learning. We want to include the creation of a virtual acute care playbook that includes the workflows Melanie mentioned, role specification, purposeful leader engagement and communication plans, access to our virtual acute care network membership, consultative services, educational materials and workshops, sharing of the Power App that we help to co-develop, as well as technology advice and a frequently asked questions section. Christiana Care's virtual acute care nursing program is unique. We are one of a handful of organizations that are live with the volume of beds that we are. Our model looks at return on investment from improvements in patient outcomes as well as patient experience, as well as improvement in staffing models whereby nurses have more time to provide direct care to patients because a virtual nurse is helping with documentation, assessments, admissions, discharges, and care coordination. We want to make sure that we are able to provide the appropriate workflows that our clinical nurses have developed and leveraged. Already, Christiana Care has had connection with over 30 organizations from across the coast. We've presented multiple times locally, regionally, and nationally from March of 2023 until October of 2023. So we're well on our way to having significant impact. The budget that we're requesting is a total of $150,000 to enable us to create that website, maintain it, provide for billing services for this as a fee-for-service program, hire a technical writer to enable us to capture our workflows in a playbook that can be published, and then the development of educational workshops with administrative fees to support their ongoing use, as well as a search engine optimization and branding and marketing. In year 2 and 3, we would anticipate additional website fees for maintenance and upkeep, as well as technology upgrades and playbook updates. We would plan to measure our success with the volume of organizations that choose to purchase our branded material for their success. Sustainability at Christiana Care is inclusive of support from multiple members of our executive leadership team, including our COO, our COO, and our CNA. We want to make sure that we continue to partner with our information technology partners and practice area leaders. We're grateful for a very diverse team, including clinical nurse specialist, assistant manager, and nurse educator.
In closing, I was ready to walk away from nursing, and I know my story is not unique, but now I have hope. With the implementation of our solution, the world will be better cared for due to our innovative care delivery model. Our model was built by nurses, delivered improved outcomes. Our comprehensive content is the guide to virtual care success, and scaling this work will make a positive impact on the future of healthcare. Thank you very much.
Well done. 5 seconds to spare.
You're on mute, Marion.
Robin, go ahead. Okay. Thank you for that presentation. Couple questions that came to mind, and I know there's other people that are interested as well, so I'll be brief. Are you doing any formal measurement of staff satisfaction? I can only assume that you are. And number 2, if you could talk a little bit more about the Power App and what that contains, that I think that was very interesting and intriguing. Thank you.
Thank you. So for your first question, yes, we've done some initial sampling of the virtual nurses who were in the role and their ability overwhelmingly to feel like they were able to impact care delivery. They were able to focus work on a nursing sensitive indicator in the course of the shift, and that they were able to relieve documentation burden for the clinical nurses they were partnered with. Secondarily, we were very fortunate to have earned a grant and help to co-develop the Power App that we're using in Teams. to mimic the functionality that we used in our initial pilot, a one-touch functionality. So at every patient's bedside, there is an iPad. It is a one-touch button for them to engage the nurse, the virtual nurse, and then it is that same one feature for the virtual nurse to connect to a patient if the virtual nurse has a question, versus if a patient or anyone who walks in the room has questions or feedback for the virtual nurse.
Thank you. Richard.
So, Robin, you asked one of my questions, and thank you. I'm really curious, what is virtual nursing? I have enough trouble with real nursing, let alone virtual nursing. And so it's a bit of a team concept. It's a bit of an iPad. I would need to understand more of that process to understand the subscription service that you're building here. You're talking about going nationally. How do you plan to address nurse licensing and across state lines, across regions? We're not in a unified license framework yet.
Melanie, do you want to answer the first question on what it actually looks and feels like?
What virtual nursing looks like. So I work both sides of it. I work at the bedside. I also work as a virtual nurse. When I am virtual, I have a group of patients, say 15 to 20, ideally, and I oversee their care. They still have a bedside nurse that is there, doing the care, passing the meds, things like that. I'm an extra part of the care team. I'm an experienced nurse. I've been around for a while. I can look at a situation from kind of a higher level, and while the bedside nurses are so busy passing their meds, turning their patients, all of those busy things were getting missed. It's like somebody's on a heparin drip. Did anybody check the PTT? Like the basic things that a critically thinking nurse that has time to stop and think, we're able to do that. And we're preventing errors and we're keeping patients safer. So we're a part of the care team that can be accessed by the nurse or by the patient. We're a part of their daily interactions.
And I would also add, patient family members, providers, pharmacists, anybody that walks in the room can engage the virtual nurse with one tap on the iPad. To answer your second question, Richard, we would not be providing the licensure we're not selling our virtual nurses from Christiana Care. We're selling, here's how you set up your program. Here's the resources that you can use. Here's the workflows that you can tweak and develop. Here's how you want to establish communication plans across your leadership teams, across your clinical nurses, across those virtual nurses that have been selected by managers to implement in your setting. We're not doing the implementation in Nebraska, New York, et cetera, but we're providing the platform of packages whereby other organizations can enjoy the same success and improvement that we have without adding FTEs.
Because we are our own nurses. Like, we didn't bring in extra nurses to fill this role, and I work on the same unit that I work for in the hospital. So I have relationships with those nurses, those providers.
All right, we have time for one more quick question, Risa.
So thank you so much for your presentation. It's so engaging because I think virtual nursing is the solution to our staffing shortage right now. So I apologize, I have several questions, unlike Richard and others. I just want to understand, this concept is relatively new, right? So my thinking is, like, in terms of safety, you have several data that you gathered from your past experience when you implemented this. What do you think is the standard in order to protect, to promote safe patient care? Since there's no standard yet across the nation in terms of virtual nursing. Number two,
Risa, I'm sorry, we're not going to have time for multiple questions. We're going to have to start the next team in 1 minute.
All right.
So I think that you kind of cut out a little. So I think that question was on the standard of care. So agree, nationally that does not yet exist. In June of 2023, myself and one of my colleagues, Maria Brown, on this team and on this call, presented a proposal to the American Nurses Association because we need national standardization around virtual acute care practice, and our proposal was accepted, and the membership voted to move forward to address practice standardization across the nation, in this model. I hope that answers your question.
As far as patient safety goes,
we're going to have, I'm sorry.
Okay.
That's time. So thank you all very much.
Thank
I know
you.
you all have a lot of questions for these groups. So thank you to the judges for understanding. We're trying to keep this on time. So next up, we have Mercy Hospital.
For our judges, that's application 359, Mercy Jill.
Can you all see our slides?
Yes.
Okay, great. Good afternoon. We are with Mercy Happy Hackers presenting our solution, Intelligent Pressure Injury Prevention. We are an interdisciplinary team of a health system with more than 40 hospitals. Our team of 7 leaders represent 83 years of experience in skin, wound, inpatient care, post-acute care, evidence-based practice, nursing informatics, and data science. 8.4% of patients enter the hospital for treatment and develop an unintended wound during their stay. A pressure injury can dramatically change a patient's life. Initial skin assessments are often pushed to the back burner, delaying interventions and causing downstream effects that negatively impact nurses, patients, and hospital systems. If our nurses complete all we ask of them related to skin, with the current ratios, it can take up to 3 hours, which is 25% of their shift. To quote from an experienced nurse, "When my patients end up with pressure injuries, after I've done everything in my power to help them with the resources available, I feel like a failure. I'm not Superman. I know what I need to do. I just can't do it on my own." Overall, the annual estimated cost exceeds $26 billion. Now let me break it down for you. From a nursing perspective, novice nurses continue to make up a large percentage of the workforce, while those with expertise continue to leave the bedside. Current skin assessment tools are too subjective. Widespread blanket interventions for all patients unnecessarily increase workload. From a patient perspective, they of course come to the hospital space to seek treatment, not harm. In one hospital, 80% of our patients with a happy experience stays in the ICU, and tragically, 25% of these patients expire in the hospital. Our hospital measures are impacted also. Patients with the happy spend 21.9 days in the hospital, which is 13 days longer than patients without hospital-acquired pressure injuries. The financial toll is astounding. A significant portion of the $26 billion is attributed to care not reimbursed by insurance companies. Imagine a single integrated solution. Clinical software in a handheld device. The clinical software transforms current risk assessments with a proprietary algorithm and guides prevention. The handheld device integrates evidence-based technology to assess moisture and temperature.
Hello?
Let's discuss the value of this device.
Well, wait, no, I'm just confused. 207?
Our innovative solution assesses risk objectively instead of subjectively. Subepidermal moisture and infrared scanning technology replaces visual assessments, empowering the novice nurse to identify pressure injuries 3 to 10 days before the earliest stages can be detected by the naked eye. Widespread prevention tasks are replaced by personalized interventions appropriate for your patient. Our intelligent pressure injury prevention prompts the nurse on their EHR integrated mobile device with guidance on the most appropriate evidence-based prevention available and approved by your hospital. Did the patient arrive with a pressure injury on admission? Our intelligent AI-assisted solution also stages and guides treatment. Lastly, data integrates with the existing EHR platform to eliminate the documentation burden and continually gather data to inform an independent AI model. Our intelligent pressure injury prevention solution offers what no one else does. All of these elements in one integrated solution. Our nurses deserve better technological tools to prevent patient harm and reduce our workload. Now I'm going to hand off to Jill to explain the business details of our solution.
Our potential customers include virtually every patient touchpoint within the continuum of care: emergency rooms, inpatient hospital units, and post-acute facilities. If you add up all three target markets, it accounts for over 75,000 healthcare facilities within the United States alone. That's over 150 million combined admissions and visits. And I want to remind you that 8.4% of patients admitted to hospitals represents 2.8 million patients per year who develop HAPIs. The market potential for our solution is astounding. Your 150,000 will go a long way to impact the lives of so many patients and the nurses who care for them. Now let's talk about our budget. Our first year will be focused on integrating data from 2 different scanning technologies to improve our proprietary model for risk assessment. Over half of our budget will be used to purchase subepidermal and infrared thermal scanners required to inform our model. Additional funds will be spent on contract engineering and developers to optimize the software and develop a prototype. Our health system will assume significant additional costs related to education, legal, and EHR integration, as well as the time of this team and all system-level support needed for this initiative. We've met with Mercy Technology Services, our System Vice President of Commercialization, our legal team, to ensure we are prepared to begin this work as soon as we are funded. In year 1, we will dramatically reduce pressure injuries at one hospital by piloting the use of these technologies within the units with the highest prevalence of hospital-acquired pressure injuries. We aim to create a truly intelligent pressure injury prevention product. Our current thinking is we will pursue strategic partnerships to support phase 2 and beyond. We had a conversation with the second largest contract manufacturer in the world to guide our plans for prototype development. Mercy has existing collaborations with Epic and a newly announced collaboration with Microsoft to develop artificial intelligence. Our innovative solution fits naturally within this new strategic partnership. While 150,000 for phase 1 focuses on our proof of concept, we've mapped out our strategic plan to commercialize our innovative solution over the next 5 years. We understand what it takes to get there, and our system has the partners and resources to make it happen. Now let's come back to how our innovative solution will benefit nurses, patients, and hospitals. Nursing assessments will be objective and prompt early detection. Interventions will be patient-specific and initiated sooner, which reduces nurse workload and moral distress. Patients will discharge earlier and experience fewer life-altering complications. Hospitals will experience improved quality measures and realize a return on investment. The potential financial impact to hospital systems is staggering. By preventing just 25% of HAPIs, hospitals could experience cost savings in excess of $6 billion nationally. Hospital-acquired pressure injuries has yet to be solved, but it can be potentially eliminated with intelligent pressure injury prevention. Technology is needed to transform the workload of the nurse, improve the experience of the patient, and increase the bottom line for the hospital. Our experienced team is dedicated and ready to take on this challenge. Thank you for giving us the opportunity to present to you today.
Hello. Oh, thank you.
Well done. I gave you 5 extra seconds because there was an interruption there, Jill. So thank you.
All righty. So judges, who has the first question? I'm sorry, I can't see who put their hand up first. Catherine, do you want to go? I can see your hands up.
Sure, I will go. And thank you for that presentation. I'm very familiar with this technology and processes. Are you working with a vendor? I would take it that is the infrared scanner. So is the vendor going to profit from your intelligence that you're building? Is this kind of a partnership with a vendor, or how's the business set up?
Yeah, great question. So the business is set up initially, there's 2 components. With the software, we will develop the machine learning here at Mercy in partnership with our Microsoft partners. The vendors, actually, we were purchasing the product for our prototypes, but we do seek to produce a smaller prototype that is integrated with both technologies to truly solve this solution. So by stage 2, we may need to partner with some of these vendors or identify a new, smaller prototype, which we have also submitted a patent for this as well.
Okay, thank you.
Other questions from the judges? Riza.
So my question is, so any new product that I see out there in the market, my question is always sensitivity, especially that you are trying to, predict, like being proactive and predicting. You said 3 to 5 days, you know how the growth of that skin ulceration would be or the progress. So in your prototype, how sensitive is the instrument in determining that?
So the instrument focuses on inflammation in the dermal and epidermal layers. That inflammation is available earlier, is seen earlier and detected by these devices that 3 to 5 days before our eyes can see it. Did you want to add anything here, Rachel, to that?
Yes, I can add on to that for you. So the sensitivity for a SIM scanner alone is greater than 80%. So our goal is to be combining the SIM scanner, a moisture detecting device, along with an infrared device to predict a greater percentage of sensitivity than just the moisture device alone.
Richard, did you still have a question? I saw that your hand was up. No, you're good. All right. Any other questions for this team then?
Marian, can I question on that?
Yes, please.
I am curious if the scanner can have is able to detect inflammatory markers, because basically when you're projecting, it's more of the inflammatory process that's happening in the skin, so that to make it more so it's foolproof that that is really what the scanner is predicting.
So between the two different devices, the way we're looking at inflammation at that epidermal and subepidermal level is regarding the temperature that it can detect, as well as the moisture it detects. And it is that integration between the two.
It is not to target the specific inflammatory markers at this point.
Okay, thank you very much. Next up, we have Christiana Care, Daring to Do for Disabilities.
Judges, application 345.
Good afternoon. My name is Kate Shady, and I will be presenting to you Building a Disability Support Network, an innovative approach to providing equitable and effective care. 7 million people in the U.S. healthcare system and 120 million people globally have an intellectual and/or developmental disability. Despite using healthcare at a disproportionately higher rate, this population remains under-researched and poorly prepared for. This results in poorer healthcare outcomes, including higher risk of polypharmacy-related adverse events and significant barriers to access of care. Meet Benjamin and Marcella. Benjamin is a non-speaking patient with IDD who was hospitalized for 3 months. He was often ignored, medicated, and developed a hospital-acquired pressure injury due to staff who didn't know how to communicate with him or understand his needs. Marcella is a patient with IDD who can only speak about 10 words and is triggered by male caregivers. She was restrained and injected with an antipsychotic when she became violent due to a male phlebotomist. The NIH recently named people with disabilities as a population facing significant social determinants of health and barriers to accessing quality care. Patients with IDD have poorer health outcomes, lower patient satisfaction, use more prescription drugs, and have healthcare costs 4 times higher than that of their neurotypical counterparts. So how can we modify the current healthcare system to ensure that people with disabilities, particularly those with communication difficulties, receive accessible, competent, and effective care that meets their unique needs and improves their health outcomes? A national study within hospital healthcare providers found that 100% of providers highlighted a lack of resources at their institution, regardless of teaching affiliation or institution size. More than half of those participants supported the concept of having specialized specific staff who were accessible and could guide their patient care. Our solution is to create a disability support specialist training program and care model that will provide 24/7 access to experts who can assist teams in caring for patients with IDD. The DSS will help with communication, accommodation, and resource acquisition for these patients. Our goal is to improve their health outcomes, satisfaction, and reduce costs and errors. The DSS network will initially consist of 10 volunteer employees with diverse backgrounds and expertise in different types of disabilities. They can be requested by anyone involved in the patient's care through a secure paging system. They will respond in person or by phone as soon as possible. This model is based on existing and successful programs at our organization, such as Language Interpreter Network, Cultural Competence Model, and our Clinical Ethics Committee. We believe that by improving care planning for patients with IDD, we will improve patient experience, treatment adherence, reduce length of stay, and readmissions, and patient harm events, all of which positively impact the financial state of the health system. In a future state, we will improve the DSS program by fostering a culture of disability inclusion. We will involve people with disabilities in our training, as research shows that this is the most effective way to increase knowledge and confidence. We will use live and digital simulations to assess and maintain our competencies. We will collect data from our interactions, trainings, and simulations to develop a virtual platform for continuous and updated disability education and programmatic growth.
Our initial target customer is any healthcare enterprise who wants to make an investment in the health and well-being of the disability community. We envision scalability to other service industries such as pre-hospital and law enforcement services. Our competitors utilize unstructured web-based learning, lacking accountability post-initial training and no follow-up. What we are proposing is a robust and evolving educational framework and subsequent 24/7 coverage care model that utilizes specially trained staff to act as an accountable expert resource. We're not aware of any other comparable solutions specific to disabilities. Our first year cost includes training materials, communication toolkits, time, consulting fees, and video and education production for a total of approximately $135,000. After year one, our ongoing costs include replenishing equipment, training new specialists for the network, and inclusion of a compensation model that supports on-call coverage. As stated earlier, this model is already successfully being used in various areas across our system. Poor communication has been shown to negatively impact patient safety by increasing risk of harm for adults with IDD and increasing length of stay by anywhere between 4 and 15 days. To estimate the impact and expense reduction from our DSS program, we added 7 days to our current organizational length of stay, and by driving the length of stay back to average for patients with IDD based on a very conservative sample size of 225 patients per year with a documented ICD-10 code, we can reduce costs from excessive length of stay by over $2.6 million per year, which represents a 20x return on investment. There is tremendous opportunity to scale with the inclusion of additional disabilities beyond IDD. Most importantly, we feel confident that this program will contribute to reductions in patient harm events, including over-medication, sedation, restraint use, and increased satisfaction with the healthcare experience. Once established, we have a commitment for operational and financial support and sustainment via our Office of Health Equity, which is included in our clinical effectiveness structure. With the DSS network in place, care looks different for Benjamin and Marcella. The DSS helps them to communicate with their healthcare team. They provide alternative communication resources and detailed plans of care for the EMR. The team felt capable and the patients felt safe. Our mission is to dismantle barriers to providing care to adults with IDD and create a network of advocates for disability equity that improves the overall climate of healthcare in this important patient population. $135,000 has the potential to yield a 20x return on investment, but most importantly, results in overall improved health outcomes for the over 120 million adults living with IDD globally.
1 minute.
Our team has the experience, passion, drive, and determination to move this work forward. My name is Brittany Anderson, and I'm a clinical nurse specialist. But most importantly, I'm a mom to a little boy with physical, intellectual, and developmental disabilities. Kate is our team lead, and she's a PhD-trained researcher who focuses on barriers to healthcare access for adults with communication disabilities, and Madeline and Jackie are our partners in the Office of Health Equity and are amazing advocates for this work. In conclusion, the DSS network is not only a financially sound investment, but also an investment that aligns with our moral and ethical responsibility to provide inclusive, compassionate, quality care that builds a stronger healthcare system for everyone. Let us continue to break down barriers, promote understanding, and ensure that every individual, regardless of ability, receives the care that they deserve.
Well done. 10 seconds to spare. Thank you.
All right, thank you. Michael, first question.
All right, thank you. This is a outstanding presentation, and you bring up a very important point, and that is the fact that in at least the pediatric community, we have learned much of how to care for such patients from parents and families. One of the questions that comes up is, I noted that you're going to start with volunteers. How are you going to select them? What type of criteria might you use? How will they be vetted? And how are you going to advise other hospitals to begin with volunteers?
Sure. Kate, do you want to answer that, or do you want me to?
You can if you want.
Sure. So we envision a system that, obviously it might be an interview process. There's nothing quite objective that you're going to put on a piece of paper that will tell you that someone's qualified to do something or not, especially in this arena. But we think a lot of this work is based on emotional intelligence, passion, and determination to want to help this population of patients. So we envision some sort of structure in that interview framework. We don't know exactly what it looks like yet, but we know that we have plenty of people in the organization that are dedicated to this work and that we think would be great advocates for it. A lot of people that are already doing it on their own.
Brittany and I also already run a disability subcommittee within the health system and have been running it for over a year. It's a group of individuals who are particularly interested in dismantling the barriers to care that different patients go through. Most of them are either parents or researchers who have spent their lives working in these areas, and that would be an important area that we would try and tap into. I know myself, I've been volunteering in a role similar like this for the past 2 years, and I get calls whenever, and that's fine. I am happy to provide that service.
Great, Kathy.
Yes, I'm just trying to understand your business model. Definitely the 24/7 access is going to be really, really important. So is your first phase just to build it out for your own system to assess outcomes? And then phase 2 is to actually sell it as a kind of a subscription model to other health systems. Did I understand that right?
Go ahead, Kate.
Yes, you did. So the first year we would spend getting it with smaller, but getting it implemented, getting sure that everyone could access it, that we were getting the patient outcomes, figuring out any bumps or barriers that we were receiving, and then it would be scalable and modelable to any other health system. There is no existing system like this anywhere. It just doesn't exist.
I know. We have our own. We have our own committee trying to do this, so I know there's no other resource.
And it's not okay. These patients need care. They deserve to get the level of care that everyone else gets. And they receive a whole bunch of issues secondary, especially to not being able to communicate. So being able to figure out, the bumps and different blocks that we come into, and then being able to model that for other systems and sell it, I think will be both profitable, but also save patients money and health systems a huge amount of cost as well.
Richard.
So thank you very much for this presentation. I see two elements here that are both very important. One is education and training for the staff that works with patients with IDD, just getting enhanced knowledge for navigating that space with the patient. That in and of itself is going to be really important. The second, and I was actually surprised by the use of volunteers, I was envisioning a translator, very much like picking up a phone to help with a different language, because navigating the health and the needs of patients with IDD is a different language. It's a different skill. So I would invite you to think about the space around translation and that model. What would it look like in versus the volunteers? So thank you very much for this.
Yeah, it's
Thank you
interesting
very
that you
much.
say that because this is
Yeah.
actually modeled after our language interpreter network at ChristianaCare, which utilizes a very similar structure and is very robust and successful in what they do.
Yeah, so we take people who work at bedside already, who work throughout the health system, and they have a dual role where their second role is as that translator, or in this case would be as that DSS advocate that would be available, pageable, and could be accessed at any point. We labeled it as volunteer because it would be in addition to their current clinical or otherwise role throughout the health system.
I'll just put in a pitch from a well-being perspective. Keeping to ask nurses to do more with less is not healthy for us. So if we're doing effort, let's find a way to pay our team members for that effort.
Yeah, we agree.
Agreed.
That's why we built in that on-call structure in year 2. And just to be clear, we don't think that this is limited to just nurses. We think this spans a lot of different specialties in the healthcare system. So, you know, it's not just nurses that can take care of these patients and provide great consult on them. There's a lot of people that are passionate about this and have a great knowledge base to do it.
I think there's also a lot of us that find respite in it. At least for me, this is something I love to do, and it's something I enjoy, and it's something different than my bedside role. So harnessing that, you know, pharmacists, anyone who works anywhere in the healthcare system.
Great. Thank you all.
Thank you.
Thank you. All right. So our last team, City of Hope, Equity Now.
Judges,
Okay,
that's
great.
application 369.
Just
You can start whenever you're ready.
Okay. Good afternoon. I'm Chris Tarver from City of Hope, and on behalf of this excellent team, I'm here to talk to you about Equity Now, a social determinants of health mitigation solution. So Maria is a 35-year-old who has been diagnosed with cervical cancer. She lives in LA County with her 3 children. In LA County, it was studied in 2021 that 3 out of every 5 residents did not have enough money to last to buy food for the end of the month. Maria is driven to her appointments by her 16-year-old son, causing him to miss school. She knows there's public transportation, but she doesn't know how to use it, and she's not sure she can even afford it. She works night shift. She lives in the bottom left corner of this map, the least affordable place to live in the United States. So the Future of Nursing 2020-2030 has asked nurses to be at the forefront of healthcare equity. The federal government, CMS, is asking hospitals, actually requiring hospitals, to start counting their patients and how many suffer from SDOH. They've chosen 5 SDOH to start with. And our patients just want us to help them. So the problem is that counting patients doesn't actually make a difference. It doesn't help the patient. And staff want to make a difference, but they lack resources, or maybe they lack the access or knowledge of resources that exist, both for the individual patient and to set up programs in order to help populations of patients. So this is our solution, Equity Now. Equity Now would be a portal that would live on the City of Hope webpage. City of Hope is a national organization. We have locations in 4 states. So every solution we've come up with works across the United States. Imagine a nurse or social worker would register on the Equity Now portal. They would then have access to all items on the left side nav bar. This would include how to give assistance immediately to patients. It would also include toolkits. The Food Insecurity Mitigation Toolkit already is created. We have disseminated it through a QR code at conferences. It's been downloaded 20 times. It includes items like how to create a discharge food bag for patients who don't have enough food when they go home. Then there's the Equity Now community. This community would exist so that people who have registered in Equity Now could upload their wins, their best practices, their outcomes from implementing their programs, and also download best ideas. There would be a section on how to use AI to help with SDOH. And finally, we would have a coalition to do a payer paradigm shift. So for instance, if now a patient was diagnosed with diabetes, they would immediately get referrals to help them manage their disease. But if the same patient said, I don't have enough money for food, there's not the same response from payers. We want to create a coalition to shift that. So who are our competitors? One of our competitors, Unite Us, they offer solutions for patients, but it's at a cost to the hospital. Our solution would have no cost to anybody who wants to join Equity Now. Epic offers solutions for healthcare providers on how to count and track patients, but they don't help the patients. And the payers help patients that are in their plan. Our solution is insurance agnostic. It doesn't matter if the patient has insurance or not. We offer a way to help. So who is our customers? There are 6,100 hospitals in the United States, but we would first focus on the list of over 1,500 public hospitals, where arguably the needs for SDOH mitigation is the highest and the resources may be not as robust. The metrics for Equity Now would be both our hospital and those in the community reporting wins like an increase in adherence to treatment plans and medication regimens, and a decrease in clinic no-shows, a decrease in inpatient hospitalizations or length of stay. So our SDOH work group at City of Hope has been meeting for over 2 years. We have created solutions like the Toolkit Food Insecurity Mitigation Toolkit that we want to get out to the world. We're asking NurseHack4Health to build us a bridge so that we can create the Equity Now portal. This portal would cost $49,400 to build, with 12% coming from labor. As you can see from our detailed budget, the majority of funds would go to getting the portal live. Because our SDOH work group has been meeting and the hospital pays our salaries, the hospital contributes over $50,000 to this solution. NurseHack4Health could amplify this money and create our solution that allow us to create our solutions that would be across the United States. So in year one, we would focus on the 4 more toolkits to then equal the 5 toolkits for the 5 SDOH required by CMS. We would launch the community and the payer coalition. In year 2, we would finish 6 more toolkits, so there would be a total of 11 toolkits available to anyone who joins the Equity Now. Year 2 and year 3 costs would just be really Marcom materials and dissemination so that people know that Equity Now exists. Year 2 would be covered by our community benefit department, of which the leader is part of our team. And year 3 would be Department of Nursing Operations. So our team is made up of what we believe is the dream team to keep making this happen. It is nursing, project management, social, community benefits, IT, and social work. And our CNO, Susan Brown, who is one of our executive sponsors, said over 2 years ago, it's never enough to just count patients, which is why we have these solutions created. 4 of us published an article in our food insecurity mitigation that was published in AONL The Voice.
1 minute.
So what happened to Maria? Maria's team logged into Equity Now. They were able to register and get her resources to cover her food needs and to cover transportation so that her son could go back to school. Our founding CEO said, there is no profit in curing the body if in the process we destroy the soul. But what we know now, 70 years after Mr. Goulter retired, is that if we don't help the soul, we don't have a chance at curing the illness. By creating Equity Now, we can help people with food, transportation, personal safety, finance, and have the best chance at curing their illness. These are our references. Thank you for your attention. We're happy to answer any questions.
Well done, Amy. 15 seconds to spare.
Thank you. Thank you.
All right, Kathy.
Yes, thank you for that presentation. Are you able to drill down by zip code to know where the resources are? So someone has food insecurity or whatever it may be in your local populations. Are you able to do that? And then if so, how do you keep it up as things change?
Yeah, so great question. So we're offering solutions that connect the hospitals with the resources. So like I said, we're a nationwide hospital. We already have created a statement on our AVS, we're Epic Hospital on the AVS, which connects patients with findhelp.org and 211.org. All the patient has to do is type in their zip code and they get the local responses. We want to get this information out to literally every nurse and social workers. We knew we had to have a solution that goes across the nation because we are across the nation. So that prints on every AVS, no matter if the patient's in California, Phoenix, Atlanta, or Chicago, and the patients can get help. So you can start using that right away, actually, let your patients know. But that would be like the kind of tools that we want to share, and we want to keep sharing it out. So that's how we solve that problem. We, even in California, our patients come, we get patients from Hawaii, we get patients all over. We're a cancer specialty hospital.
Great, Katie.
Yeah, thanks for that presentation. I'm curious about when you say connect them to help, could you just explain that a little bit more? Because, you know, we all know about some of these agencies where patients have to get help. They're bogged down, you know, long wait times to get someone on the line. We know, and I'm also curious also about how this connects to public health, community public health centers, right? That, you know, are doing geospotting and doing some of this work as well. I'm just curious about whether there's any linkage there.
Yeah, I think there's two levels to the information that would be in Equity Now. So one would be for the individual patients, like we need help now. So there's a couple of different ways to connect. So one is, like I said, through the organizations that we've already vetted out and found, like what I was just answering. The other one is we've tested out using AI for immediate help. And there are ways to ask questions, which is what we want to put on that part of the nav bar, like ask a question this way, and you can find out what help is available in your local area. In connecting with public health, we haven't done a ton of that. In our toolkits, though, we offer solutions like on how to set up a produce for patient program where you connect with local farms. So we have like the whole playbook on how to do that.
Great, thank you.
Marion, this is Nancy on the Equity Now team. If I might respond just a little bit more to what Chris had just said. The Food Insecurity Project, Katie, is what we've been working on for the last couple of years. It is a system-wide coalition of the 5 nonprofit hospitals within the San Gabriel Valley. We received a grant from the UniHealth Foundation so that all 5 of the hospitals can develop systems in play to connect patients with food resources. The health department is one of those collaborating partners since its inception. So whatever we're creating together is shared across all 5 of the hospitals in the San Gabriel Valley. And in the toolkit, it provides all of those examples on how those connections are made.
Thank you. Thanks, Nancy.
Thank you. Michael, your question?
Yes, I'm always concerned about addressing social determinants of health through modern technology, since one of the issues regarding people who need help in this areas, we're assuming they have an iPhone or a computer, that they have access to the internet, that they have some mobility in going to where the agencies are, and it's often in one language. And so how do you reconcile this? How do you look at ways such as partnering with the public library, which has all sorts of computers, or bringing services to the public library? I love this concept. However, I would not like it to select and not be available to some of the neediest groups for addressing their social determinants of health.
Yeah, and we agree with you. So our audience is really the healthcare workers and the social workers who are helping the exact people you're talking about, and that's some of our patient population also. And so So we're giving the tools to then we're giving the tools to the healthcare workers, social workers, healthcare team to then work with the patient. So you're right, not every patient has that kind of access. And like cards to go shopping, they can't even get to shopping. So we have solutions. We have a playbook how to, sorry. Did you say time?
No, you keep fading out. So I just wanted to make sure that we get to hear your response.
Okay, I'm sorry. Did we freeze that? So what I was saying is that our audience is really the healthcare workers, social workers, nurses. And we understand too that we have patients also that struggle with not even having technology. And so we have solutions that can go across any kind of patient needs. So for example, for patients who have a food insecurity, we have a recipe playbook, how to create a discharge food bag that is non-perishable foods that could last a family of 4 for 2 weeks. And we also have instructions like how you can work with your vendor to get that at cost, which is what we were able to do. So even like patients who don't have transportation or the energy because they're too sick to go shopping, to go buy their own food, like giving them a gift card to a store doesn't help. So here's just another way to help. So we agree, like our audience is really the people helping the patients rather than the patients themselves, and how to create solutions for them. Did that come through?
Yes, great. Yeah. Thank you. All right, so I think we're basically at time. So thank you to all the teams who presented your incredible solutions. We really appreciate the hard work you went through over these last couple of months, and it really came through so clearly how much time and energy you put into this. So thank you very much for that. So next up, the judges and some of the organizers are going to go to a separate room. For all of you who are waiting anxiously for the announcement of the winner or winners, we'll have you come back at 6:15 for that. I would suggest just going on audio and video mute instead of logging off and logging back on, but it's totally up to you. But at 6:15, we will make the award announcement. Nico, do you want to pull us where we need to go?
Will do. Just going to take me 2 seconds to get everybody into the breakout room, judges. So bear with me. All right, folks, thank you for being so patient with us as the judges were deliberating.
Is everybody back, Nico?
Yep, you're all back.
All right. Well, everybody, thank you for participating. Thank you for listening to all the teams. Thank you to our judges and our volunteers. Can you go to the next slide, Nico? We were all discussing that we all feel like proud mamas listening to your listening to your pitches. You all killed it. Honest to God, it was impressive work all the way around. And so next slide. So again, I just want to thank all our volunteers, our coaches, our mentors. We couldn't do any of this without you. Next slide. So the next steps for all of you, there are additional innovation opportunities. So you can attend the March 2024 Sanciel Drexel University Nursing Innovation Certificate. Join again the Nurses Know Patient Safety Technology Challenge that we have that will give additional funding as well. And look for new NurseHack4Health Innovation Sprint at AONL 2024. And then learn more and apply to become an all-in well-being First for Health champion. Next slide. And connect with us. Here are all our social media contacts. We'd love to stay up to date with all of you on resources and opportunities. And the moment that you've all been waiting for. So I am now going to turn it to my colleague, Kasha. It's all yours.
Thank you so much, Hiem. And I just have to congratulate everyone. I mean, honestly, we wish that we had funding to award you all. What I will say, just one moment before we announce the awardee, is that this is really just, I know we said it at the hackathon that it was the beginning, but this is also the beginning, not only for obviously the awardee who receives the grant funding, but also for all of you. This is not the end of the road. And what I would encourage you to do is take what you've done here, bring it to your executive leadership, bring it to other funders, because this work is so important and we can only encourage you. We'll help support you along the way. But I just really want to just stress that you have so much potential and opportunity to bring these ideas to life. So with that, I will announce that the awardee is, next slide, please, Vancouver Coastal Health with AutoChart. You will receive the full funding of $150,000 to bring your solution to life. We are so grateful to all of the finalists who pitched your ideas today. I know it was no small feat to bring your ideas to this collaborative and also just put in the time and energy into these solutions. We are so grateful for your participation, and whatever we can do to help in the future, please do let us know. But congratulations, AutoChart, Vancouver Coastal Health, and the team listed here.
Thank you so much. We're so excited. We really didn't expect to win. So this is such fantastic, excellent news. We can't thank you enough. Thank you so much.
Nico, did we want to do a picture?
Yes, please. Let me just set this up for everyone. Kathleen, just remind me if you're still on the call, if there's a certain little button I need to click to make sure everyone, oh, so here we are, select for everyone. Okay.
Yep. Little tick box.
All righty. Wow, folks. If anybody wants to join in, please feel free to jump off to your video. Excellent. Thank you so much.
Congratulations to everyone for your wonderful ideas.
Good night, everybody. It's really been an honor to work with all of you.
Congrats,
Great job.
everyone.
Great
Good
job,
night.
everyone.
Thank you.
Thank
Bye,
you.
everyone.
Bye-bye.
Thank
Thanks,
you.
everyone.
Thank you. Bye.
Congrats, bye.
Thank you. Bye-bye.
Congratulations. Thank you, everyone.
Thank you.